you. Thank you very much and welcome to everybody to the webinar tonight brought to you by the Orthopedic Research and Education Foundation through OrthoTV. Today we have the pleasure of having Dr. Swarnendu Samanta from Kolkata. Everybody should know about him. He's very academically involved in various fields of orthopedics and has been a regular feature in the academic circles for the last many years. A great friend of mine, and it will be a pleasure to have him talk to you today. So he's going to talk to us about shoulder examination, and over to you, Swarnendu.
Okay, sir. Thank you. I think I can start sharing, sir, with your permission.
Sure. Please do.
Okay, so it is a great honor to be having here with, and that too with one of my teacher, mentor, and also one of my elder brother, sort of, Dr. John Mukhopadhaya, who is a world-renowned figure. And also my dear friend, Dr. Janki is also here. Welcome to everybody. I will just start sharing.
Sure. Yeah, you need to go full screen. Yeah, great.
Janki, has it come in full screen?
Yeah, it's fine.
Yes, sir.
Okay. So welcome all the seniors and juniors, whoever is there and whoever is joined here. So first I will be talking on how to examine the shoulder. Then I will be talking how to read the basics of the shoulder MRI. Then we will be taking the questions as John sir has told. So I think examination of the shoulder is very, very important for the MS and DNB people, and also for us also, because we have to diagnose this clinically. As we all know, so whatever joint we examine, there is certain protocol of examining, like ask, look, feel, move, measure, and then the special test. Similarly, it is all true for the shoulder joint. I think it is more true for the shoulder joint, because if we patiently listen to the history, most of the shoulder problem can be diagnosed if we carefully listen to the history. And also remember that there are certain pathologies. Suppose we want to diagnose something like in the shoulder, there are common problems that are around the shoulder is either the rotator cuff related disorder or the instability or the labral lesion, then the arthritis and the miscellaneous like your frozen shoulder and the cervical pain, etc. Remember, whenever we take the history for the shoulder, the age is very, very important. Because if we take these ages like from 20 to 30, mostly these people will be coming with either the problem with this instability, or there is some problem with the biceps or the slap lesions. From 40 to 60, there will be degenerative problem, and also there will be some calf related issues. More than 60, there will be calf related issues itself, and also there will be some arthritic problem. And we must have the history of the occupation of the patient, and also we must know whether it is a dominant side or the non-dominant side, and whether what is the sports, what sort of sports he is indulged to, and whether there is any overuse issue, whether there is any prior injury to it, right, for the recurrent dislocation or the post-traumatic arthritis in the aged group. And we have to also exclude like the other joints when we examine like the systemic inflammatory disease and the previous treatment. Then as in for the other joints like your hip and knee, when we examine, the pain has to be like where is the location, then the character, the night pain, whether it is there or not. Mostly for the night pain, we usually find in the diabetic people, calf-related disorder, then the weakness, the aggravating and the relative relieving factors. Then in the younger group, we have to see for look or the ask for the locking, clicking or the clunking sort of feeling. Then what is the movement and the what related issues. So whenever we examine the shoulder joint, we have to, suppose we have taken the history properly, listen carefully, then we have to look for the shoulder. And we have to uncover the shoulder with proper dress code so that we can examine the shoulder not from the front. We have to examine the shoulder from the front, from back, from side, and from the top. So it is more or less like 360-degree vision of the shoulder. Unless we take the shirt off or we take the garments off and we expose the shoulder properly with the permission of the patient, we cannot see the front, back, top, and side of the patient of the shoulder. Then we have to see the height and the scapula, whether there any asymmetry, obvious deformity, is ecchymosis or the muscle atrophy for the supra, infra, or the delta. So whenever we examine the shoulder, looking the shoulder from the not only means that you have to look only from the front. It is like a 360-degree vision, like front, back, side, and top. Like this way, you have to see. Unless you uncover, you cannot see the scapular position, or there is some atrophy of the supraspinatus or the infraspinatus on the medial side, or there is some subtle winging or subtle deformity of the supra and infra, or like this sort of from the front, whether you can some of wasting of the deltoid, also from the some problem in the front, like in the pectoralis. So whenever we start palpating for the shoulder, always remember that patient should sit comfortably on a stool, so that at rest, or we have to palpate everything, or at rest also allow with the movement, the bony structures, the joint, and the soft tissue. So when there is a protocol of palpation, like we start from the AC joint, sternoclavicular joint, then you palpate the clavicle, then the AC joint, the acromion, the coracoid process, the biceps tendon, and the posterior rotator cuff muscles. So this is the protocol how we palpate around the shoulder. And this is for my dear PG students, that we have to remember this, that what is the range of movement, like active and passive. Whenever we test any joint, like for the hip or the knee, we all examine the active and passive range of motion. So you have to remember what is the range of motion, like forward flexion is 160 to 180. The extension is 40 to 60. The abduction is 180. Adduction is 45. Internal rotation is 60 to 90, like up to T7 or the dorsal 7 level. External rotation is 80 to 90. So this is the way you have to, when you read the classic textbooks or the examination book, you always remember that the scapula is exactly not at the coronal plane. It is 30-degree oblique in the frontal from the coronal plane. So whenever we test, basically whenever the examiner asks for, please show me the abduction or the forward flexion, please remember this, the pure abduction or the pure flexion is 30-degree oblique. So it has to be in the scapular plane, because the scapula is exactly not at the coronal plane. It is 30-degree tilted in the front. And this is the way how you have to show your external rotation or the internal. It can be at the side, or in 90-degree abduction, you can show the external rotation or the internal rotation. Like this way, your internal rotation, or we can see the scratching the back sort of thing. You can feel your external rotation and internal rotation. In adhesive capsulitis, there is global restriction of lost range of movement. The fast movement that goes in the adhesive capsulitis is your external rotation. Then measurement, you can have the limb length, like this is for the exam purpose from C7 to radial styloid, the arm length from the angle of the acromion to the lateral epicondyle, and mid-arm circumference. The muscles to be tested around the shoulder is your deltoid, the lat dorsi, trapezius, rotator cuff, serratus anterior, and rhomboids, other than your other muscles. So special test is also there for the instability, like your anterior instability, posterior instability, the multidirectional instability, and the slap results. Stability of the shoulder, better to test in the So for the stability of the shoulder, you can test this way. So always remember that you have to test this. You have to test this. You can test this in a sitting position or the lying down position. So suppose I want to test the stability of the ambient and the application test. Basically, I will do this 0 and accelerate. And I will gradually rotate, accelerate, and I will do pattern test. And also I will ask it whether he is telling. So basically, you have to look to the face of the shoulder. You don't, basically, you are not intending to dislocate the shoulder. So it can be tested in the sitting position, in 30°, 60°, and also in 90°. Extra rotations. So always. This 30 to 60°. This is known as the mid-range instability. This can also be tested. The apprehension can be also tested in the sitting down position in 0°, 30°, 60°, and also in 90°. Test is known as the crack test. Basically, the crack test is done in this position in 160° of abduction. Okay, crank is just like suppose you want to rotate the humeral head on the behind, and you rotate the behind head with some sort of axial pressure. And so this is just the compression of the humeral head on the glenoid. So this is the crank test with the axial load. Lateral here, either in the front or back, you will feel the crank. This is the lobe system. How you do it? Your one finger will be on the thoracoid, and this thumb will be to stabilize the scapula. Now you hold the humeral head, and you see the humeral head. Try to see the humeral head front and back. So this is known as the lobe system. If more than 50% of the shoulder can be out in front or backwards, then there is either anterior or posterior lateral. So this is the lobe system. So for the instability, always remember that you have to test 3 tests. One is your classic apprehension test. Remember, the apprehension test can be done both in sitting or the lying down position. First, you have to explain what you are going to do. Then you explain it and do it on the normal side. Then you do on the pathologic side. Then remember, it is not done only at 0. It has to be done at 0, 30, 60, and 90. And look at the face of the patient, because whether he is apprehending that it might dislocate. So that's why it is known as the apprehension test. Then your Job's relocation test. The same thing you do, but with the palm. When he is apprehending, you put your palm on the front of the shoulder, and then he will feel comfortable. See the face of it. Even you can ask the patient whether he is feeling comfortable. Now suddenly, if you take your palm off, again he will be apprehending. So this is known as your Job's relocation test. Then you can test the crank test. Also, you can do the load shift test. So 3 tests for the instability that you remember. One is the apprehension, which can be done in lying and sitting in 0, 30, 60, and 90. Then your load shift test, Job's relocation test, and your crank test. Then rotator cuff related disorder. Either it can be impingement, then the subacromial bursitis, and the cuff tear. So I think we have to read properly what is the impingement sign. Charles Need describe this. The arm is fully pronated and placed in the forward flexion and trying to impinge the subacromial structure with the humeral head. So if you remember this picture, if you pronate the arm like your empty can and you gradually elevate the arm from this position to the utmost forward flexion, so that the humeral head with your supra will be impinging on the undersurface of the acromion. So this is known as the classic impingement sign. The sign and test is different. Sign is this one. When we inject some local anesthetic and then we see if there is pain relief, then it is test. When we do this, this is the sign. When we inject with the local anesthesia and see whether there is any pain relief, then it is the knee test. Then you can do this test like you have this. There are two sort of impingement that you can have. One is the extrinsic, another one is the intrinsic impingement. You can do also the Hawking-Kennedy test like this way. You can forward flex at 90 degree, and the arm is not like this way. It has to be in the plane in the forward flexion position. Then at 90 degree position of the shoulder, forward flexion and abduction, if you just rotate the arm, then humeral head will come under the acromion and there will be impingement. So this is the way how it is done. This is the classic picture. The hand, the shoulder should be at 90 degree. It should be, the thumb should be down and pronated. Then you have to rotate it so that the humeral head along with the supra that is going to rub on the undersurface of the acromion. So this is the classic way how the Hawking-Kennedy test is done. Then the test for of your four muscles which constitute the rotator cuff. One is the supra, then the infra, then teres minor and subscap. Remember, for the exam purpose, you need one test for your four muscle. For the supra one, infra one, teres minor, and then the subscap. So this is the classic test. How it is done is you have to abduct the arm in the scapular plate. As I told you that the pure abduction is never from the front way. So you have to be in the at the level of the scapular plate. This is the bear hug test, which is another one test which you can do for the subscap. Classically, we do the belly press test or the Napoleon test. Then for the biceps, you can I will test you. Then this is the way how you do it. Yergersen test. Elbow is flexed at 90 degree. Start in the pronated position, because you know the biceps is the both way. It has got two functions. One is it is flexor and also is the supinator. So active supination and flexion against resistance. So if you keep this forearm and the arm this way, and you try to and ask the patient to do the flexion and supination against resistance, then you can test the biceps. Also, your thumb should be on the biceps, on the bicipital group, so that if there is any tenderness, then the patient will tell you that this is causing pain over there. And also you can test whether he can actively flex and supinate against resistance like this way. Then the drop arm sign that we all know, the drop arm sign and the horn blower sign. The drop arm sign test is classically is the test for the both when there is a tear of both the supra and infra. So once the patient, when it is fully abducted, and ask the patient gradually to come down to 0 degree of abduction, suddenly from 90 degree to 0, when he cannot control it, suddenly arm will drop. So if there is a tear of both the supra and infra, then suddenly the arm will drop. He cannot or she cannot do it in a gradual manner. Suddenly it will drop. So that's why it is known as the drop arm test. Then you have to test for also the AC joint. This is also very important. The patient will classically point at the AC joint with his finger. That's why it is another one name is the finger test. He will certainly with the index finger, he will tell that this tender point is at the AC joint. Then crossbody adduction test is also for the AC joint. Like arm is flexed at 90 degree and adducted to 45 degree like this. This is crossbody adduction. So if you do this, then he will be telling that he or she will be telling that he will classically feeling the pain at the AC joint. Then I think once you have done the test for the instability, as I told you, for the instability, you have the 3 tests that you have to remember. Then for the cuff, you have to remember 4 tests. One is for the supra, one is for the subscap, one is for the infra, one is for the teres minor. remember for the supra, you do the Jobs test. For the subscap, you do the belly press test or the bear hug. For the infra and for the teres minus, remember these two muscles are the external rotators. So in 0 degree of adduction, if you ask the patient to externally rotate, that will test you for the infraspinatus. At 90 degree of abduction, if you ask the patient to external rotate, then you test for the teres minor. So remember that when you test the external rotation at 0 degree, that is the test for the infraspinatus. When you test the same thing, external rotation at 90 degree, then this is the test for the your teres minor. So 4 tests you remember. One is Jobs test for your supra, the external rotation at 0 for your infra, external rotation at 90 degree, that is for your teres minor, and the belly press test or the lift off test or the bear hug for your subscap. The examiner is very fond of asking you how to test the pectoralis later. Then so the other muscles that you have to test. So this is the test for your pectoralis. Remember, the pectoralis has got 2 heads. Want to test the clavicular head, we will just ask the patient to go to the opposite shoulder this way and we will resist. Try to do that, please. That's what you try to do that, go to the other shoulder. So this is for the clavicular head. This is for the clavicular head. Start the head test. When you ask the patient to move this arm towards the opposite anterior to medial spine. So from that position, we ask the patient. So basically now the arm is going to the other anterior superior iliac spine. When you do like this against resistance, then you will be testing the other head of the pectoralis. So here then you see now we are testing the lat dorsi. The one thing if you remember for lifetime, you will remember it. The latissimus dorsi is like, just like the handling the X. So it is extensor, adductor, and interrotator. So ask the patient to put the moving like this way. Okay, just like the capital. So we will put the foot this way, 90 degree with the scapular plane, and I will resist and I will ask the patient to take down the arm like this. And you will also feel the maximal dorsal here. Okay. Please pull your line. Yeah. So this is the way you take the maximal dorsal. Thank you. The maximal dorsal, ask the patient to keep this arm. This is the test for the rhomboids. So your palm has to be on the other SI joint. Ask the patient the arm like this. Okay. And you will feel with your index finger whether these rhomboids are contracted, both in the rhomboid major and the rhomboid minor. Okay. Thank you. Now we are going to test the trapezius. Extend like this. So this is for the upper trapezius. Okay. Do that. So this is for the upper trapezius. Okay. So the middle part. Then you can taste also the middle part of the trapezius and also the lower part of the trapezius. Then it is better to taste in the prone position and note the position of the arm. Test the middle part. And again, same way, you keep it in 120 degree. Then you ask the patient to extend. Then you test the lower part. Okay, the lower part is like this. Thank you. So I think whenever we test for the instability or the cuff or the other muscles, never forget in the exam purpose that you check the laxity of generalized laxity of the patient. We know that what is the vital score. It has got 9 points. Like you see how the MCP joint is doing, 2 points. Then the elbow, knee hyperextension, whether the thumb is touching on the forearm, and also the whole palm is touching. It is 9 points. Then we all know if it is more than 5, then it is a hyperlax patient. Test for the dislocated shoulder. This is also we can test. I'm not going to the detail of this. These are all the names: the Hamilton ruler, the Douglas test, the Callaway, and the Bryant sign. The arthritic disorder, the related disorder, I reduce range of movement in all plane. Painful crepitus will be there. The rotator cuff dysfunction, sometimes the rotator cuff arthropathy or the calf tear arthropathy. Then the systemic feature of the disease, if there is any inflammatory problem. These also we can have during the history taking. And never ever forget to examine the cervical spine and the neurological examination, because sometimes the cervical problem or the neurological issues can mimic the shoulder problem. So always examine, unless and otherwise you do the examination of the cervical spine, your examination for the shoulder is never complete. Unless and otherwise you examine the neurological status of the limb, your examination for the shoulder is not complete. So always see the tenderness in the cervical spine, the neck movement, and quick neurological examination. So to summarize, when you examine your shoulder, please remember that you listen to the patient's history very, very carefully. Because from the history itself, most of the shoulder pathologies or the disorders can be diagnosed. Then age is a very, very important criteria. Then look the shoulder from the front, back, side, and the top. Please uncover the shoulder. Don't examine the patient with the something on the shoulder, because he will look many things. He will miss many things. Then see for the wasting. This is very, very important. And they always note during the movement what is the rhythm of the scapula, whether there is any asymmetry of the scapular motion, whether there is any winging. Another one test I forgot to test you, what that is the winging. That when you press both the arm on the on your wall, you have to see what is the movement of the where is the your medial border of the scapula is staying, whether it is classic, whether both the scapula are looking at same area, same way, or there is some winging of the scapula, because this is the weakness of the serratus anterior. Then look for the tenderness starting from the sternoclavicular joint, then the clavicle, then the AC joint, then acromion, and gradually you go back. Then you come to the humeral head side. And you do the classic test for your instability. If you are suspecting from the history instability issue or the age is fitting to, then you have to test the range of motion. And you have to test your, also you have to test for the rotator cuff related issues, all the tests that you have to remember for the supra, for the infra, for teres, and for the subscap. And lastly, the biceps. And the range of motion, the painful arc, the adhesive capsulitis, the fast motion that goes off in the adhesive capsulitis is your external rotation. And the special test. Another one special test I forgot to tell you, that is the O'Brien. O'Brien is similarly like your empty can. Empty can is done at 90 degree of abduction in the scapular plane. But the O'Brien is done when it is forward flexed and both the palms are together and his finger is pointing downwards and pronated at 90 degree. And against resistance, if there is pain, then it is for the slap reset. But there is no classic test which can classically diagnose the slap. You can do the O'Brien, you can do the AR, that means ABAR test like 90 degree abduction and extrusion for the slab. But mostly from the history, when somebody, young people, they complain of throwing problem, throwing disability, and sudden fatiguity after playing, then it might be a slap problem. Then you remember this, the Hawkins test, the Jobs test, the external rotation, the Garber impingement test, as I told you, the Jobs impingement, the apprehension, as I told you, remember it has to be explained first to the patient, explain it and do it on the normal side, then come to the pathological side for your exam purpose. The Jobs relocation test, never forget to have the Byton scoring for your laxity, instability. Then O'Brien, as I told you, the crank test, Yergason for your, again for the biceps, the labral tear and the slap tear, as that the classic test is the O'Brien test. And I will request whoever is interested to for this shoulder, please read once the Professor A.K. Saha's article of the classification of muscles of the shoulder. Because sometimes those who are the examiners who are fond of this article, they might ask you who are the prime movers, steerers, and depressor. Because in that article only he described, and it is a world-renowned article. This is the zero position and the how the muscles are working. Like the prime movers is the deltoid and the clavicular head of the pec major. The steerer are the three. One is the subscap, supra, and infraspinatus. Remember, the subscap and infraspinatus is the force couple. Along with the supraspinatus, it becomes the steerer. And depressor are the sternal head of the pec major, the lat dorsi, teres minor, and teres minor. So remember, if you read the Professor A.K. Saha's article, there are three group of muscles which act around the shoulder. One is the prime mover, second is the steerers, and then the depressors. Thank you very much for your kind and patient hearing. If there is any question, if I forgot anything, I think John sir will tell us, then we can discuss.
No,
That.
thank you, Swarnendu. That was great. Thank you very much. That was a very informative and comprehensive talk on shoulder examination. I thought you were going to do MRI at the end of it. What happened?
Yeah. I will be talking on the MRI also. Should I take the MRI lecture now, or at the end of it, we'll take the questions?
Yeah, that's probably better that you finish everything and then we take questions.
Okay.
How long will the MRI take?
Okay, sir.
How long will the MRI talk take? How long will the MRI talk take, Swarnendu?
Sir,
How long will the MRI talk take?
MRI will hardly take 10-15 minutes time.
Okay, 10 minutes, because after that
10
will
minutes,
be
okay.
time for questions. Okay, great. Thanks.
Is it coming?
Yes, sir.
Okay. So I'll be going through the basics of the very basic of the shoulder MRI, so that our junior colleagues can understand how to read the MRI of the shoulder. So as we train our eyes during the knee MRI, you all know how to go ahead. What is the, even we see the spine MRI, you know what is the T1 image, what is the T2 image, what is the fat side image, or the proton density. I am not going to very detail of that, how you know that. But remember two things. One is the how to remember which one is the T1. T1, you see the fat signal is bright. In T2, you know that your water signal is bright. So if you remember that, you will remember most of the things. In knee, we see the coronal sections, the sagittal section, the axial section. Same is true for your shoulder thing. So we know that in the shoulder, we have got three sort of cuts. One is the axial cut, one is the coronal oblique cut, and the sagittal oblique. Why it is oblique? Because we know as I told you, the scapular plane is 30-degree oblique from the coronal plane. So it is not classical, it is not classic coronal, it is axial, coronal, and the sagittal oblique. So if you see this sort of anatomy, and this is the anatomical cut, and this is the, on the right side, this is your MRI cut, always you see where is the biceps is located, you will be knowing that this is the front side. Then you see the glenoid here, then you see the glenoid here, you can see the labrum well here, and you can know this is the glenoid. This is the axial cut. And if you see, this is like your AP X-ray. So once you see the AP X-ray, this is the normal anatomical specimen cut, and this is the MRI cut. You will be seeing your this way, like this. The supra is coming, the glenoid is here, the humeral head, and the AC joint also you can see. Then this is the sagittal oblique. You will be coming from the deltoid side. You can see the ice cream sort of cone sort of thing, or the humerus. Then you can see the cover. Then how you know which is the front side and back side? Always remember to see the acromion. Acromion will be coming. The back side is downwards, the upside, because you know the acromion will come from the down to up, from the back to front. So if you see the acromion, you will be knowing which is the back side, which is the front side. So this is the front side. If you can see this, so this is the subscap, this is the supra, this is the infra, and this is your teres minor. Even if you can go deeply, even you can see the coracoclavicular ligaments like this way. And you see, this is the acromion. So now you can understand this has to be the subscap, supra, this is the teres minor, this is the infra, and this is the teres minor. So now if you remember this, suppose you see this coronal oblique cut, this is the, you see, there is some white signal inside it. So this is the partial, there is degeneration in the supraspinatus tendon. So this is the tendinitis of the supraspinatus tear. Now there are you can classify the tear like the either this is the bursal side tear, the complete tear, or the articular side. That is known as the ABC. A means articular side, B is the bursal side, C is the complete tear. Also sometimes you can say, you see this sort of MRI, once you see there is a partial tear, that is the partial articular side tendon avulsion. So this is known as the pasta lesion. If you see this sort of tear, again you can see the tear on the bursal side. And if you see this sort of picture, you see here there is this is the diagrammatic depiction. And now you see, if you go back to the MRI picture, there is a superior leaf, there is an inferior leaf, but there is same degeneration in the intra-substance. So this is the intra-substance tear. Now you see there is no continuity in the tendon here. So this is the complete cuff tear. You can even, if you see this sort of cut in the other cuts, you can see the scapular Y view sort of thing. Once you take the X-ray, this is the Gutelier classification. You can see the whole muscle when it is like a grade 0. And if you go to the grade 4, you see the muscle mass is completely been replaced by your fatty signal. The white signal is the fat signal. You can also have the tangential line. You can see the muscle, and you can have the fatty degeneration around. Sometimes also you can, in the coronal oblique cut, you can see the IGHL properly. You can see this is the normal IGHL. And if you see the toned IGHL, there will be a J sort of sign, and there will be a lot of fluid inside. Then the acromial shape also, the Bijlani classification 1, 2, 3, 4, that can be even classified in the, you see the hook sort of acromion here. Then bicipital, as I told you, when you see this glenoid, this is the anterior labrum, this is the posterior labrum. You see the bicep, there is no fluid in the normally. But if you see this picture, lot of fluid around the biceps tendon. So this is bicipital tendinitis, and this is pathological. You see, this one is pathological. The subscap tear in this axial cut, you can see that the subscap, as I told you, it will be coming at the medial margin of the biceps. Yeah, but there is discontinuity in the subscap for muscle and the tendon. You see, this is the classic picture how you find your Bankart lesion or the bony Bankart lesion. The labrum is completely off in the front, and also you can see lot of hemarthrosis, also fluid inside the joint. Also there is marrow edema inside. So this can be classified into different ways, like the Bankart, reverse Bankart, the ulcer, the anterior labral periosteal avulsion. That all you can see in the MRI pictures. You see, you have to train your eyes. Don't miss the Hagel lesion, humeral avulsion of the labral ligament. This is the way, because if you just repair your labrum, it is a day one failure if you miss the Hagel lesion. Even sometimes you can see the posterior labral flap tear, just the reverse of it. You see, the fluid has gone inside the labrum. Here is the distal or meniscal tear. The slap tear, it is very difficult to diagnose clinically. As I told you, there are a lot of tests for that, but like your Abbott test or the O'Brien test, but the history will tell you. But sometimes for the slap, we have to do the MR arthrogram, and you will find that where the biceps anchor is going to be at 12 o'clock, you will find fluid under this labrum. So this is the classic picture of your slap tear. Sometimes you can see this is known as the suprascapular notch ganglion. So this, because of the slap tear, the fluid goes there, and there is a formation of the ganglion which can compress the suprascapular nerve, and this will give rise to the wasting of the infraspinatus. Even with this axial cut, you can see there is a big Hill-Sachs lesion. So you cannot miss that Hill-Sachs from here. Even in this cut also you can see, but better to take this axial cut so that you can understand. You can see there is a, you can whether there is any tear in the front, but mostly you will find with the instability or the recurrent dislocation, you will find this sort of Hill-Sachs in your picture. Sometimes in the picture X-ray you cannot miss, it may miss, but in young people, if there is gross tenderness, you can do the MRI, just to understand whether, like your marrow edema, what we see in the knee, you can find this sort of marrow edema, a small crack in the greater tuberosity. So as I told you, whenever we see the patient for the shoulder, the history will tell you the diagnosis and the age will guide you to the diagnosis. And the most important thing is the clinical examination. Never jump to the MRI picture or the X-ray or the USG, whatever. History, age, and clinical examination is the key for any joint examination or for any orthopedic examination. Normal MRIs of the shoulder, you must train your eyes, the axial, the coronal, and the sagittal oblique cuts, so that you can understand what is the normal picture. And remember, the T1, the fat is bright. In T2, the fluid is bright, the water is bright. And take the cut accordingly, so that you, once you have diagnosed clinically, then take the, suppose you are diagnosed is instability, take the axial cut first. Suppose you have diagnosed the rotator cuff, take the coronal cut, and next you reconfirm it with your the sagittal oblique cut. So I think this was very, very brief, just for the sake of basic understanding of the how to read the MRI of the shoulder. The still the clinics is the main part. Thank you very much for your kind and patient hearing.
Thank you very much, Swarnendu. I'm sure there will be questions, so I think we should open it to questions and then we'll have the final closing. So,
Yes, sir.
Janki?
So while we are waiting for the questions, sir, the most common diagnosis usually what most of the orthopedician used to give is frozen shoulder, sir, or pericapsulitis. So how to overcome those, sir? Because most of the things you have covered, but in
Yeah,
which
yeah.
case we can label it as frozen shoulder?
I think frozen shoulder is a misnomer. Lot of people, the academic people, they don't write, even they just abandon to write the frozen shoulder as a diagnosis in our prescription or description. Is better to go ahead with the adhesive capsulitis. But the problem is the frozen shoulder, as I told you, that the fast motion that goes is the extra rotation. Then the global restriction of the movement. Then the problem is that frozen shoulder is basically the corollary of one problem, unless and otherwise he is very diabetic, or the mostly the diabetic patients, they get ahead, we go ahead with the frozen shoulder. So you have to rule out the common medical issues which goes. But sometimes with the pathologies, right, the rotator cuff problem, they can land up and come to you as a frozen shoulder or as adhesive capsulitis. The problem is that when they come, the rotator cuff issues or the other problem come with, suppose they don't have any medical issue, and the young or the guy who is around 60s is having a frozen shoulder, then you cannot taste your cuff. So that is the problem, because you cannot abduct the arm at 90 degree, or you cannot taste only you can taste at 0 degree. So diagnosing the frozen shoulder, you have to rule out all the medical issues, see the extra rotation and the global restriction of movement, even the night pain is there, and then you have to investigate properly with the X-ray. And I always do classically the USG, because the basic advantage of doing the USG is that it is dynamic, one thing. Second thing is that we can test both the shoulders. You I don't jump around with the MRI fast go, because the unless and other, mostly the physio or the rehab will do. And if it is very, very recalcitrant, suppose after 6 weeks, even he is not or she is not responding to any sort of treatment, then we go ahead gradually. But frozen shoulder, classically, diagnosis clinically, rule out the medical issues, and do the X-ray and the USG.
Dr. Rajan has asked about examination of SLAP and HAGL.
Yes, the very good question. As I told you, there is, if you go ahead with the literature, even in the textbook, there is no single classic test which will tell you that this is a slap lesion. Like a O'Brien, you can do, as I told during the discussion, or else another one test that you can do is the 90-degree abduction. You can external rotate. This is the ABAR test that you can do for your slap. But the most important clue for your slap is the throwing disability. The patient will is young and he will tell you, suppose he is playing the overhead sports, then he will not be able to serve it properly for the tennis. And the suppose who is playing for the cricket, he will not be able to throw the ball from the boundary. So there is a pain issue, throwing disability, the O'Brien test and your the Abbott test will and will the tenderness along the bicipital area that will tell you the diagnosis. But there is not a single classic test which will tell you for the slab. And the problem is that even simple MRI also cannot sometimes do the diagnosis for the your slab. For the slab, there are different classification for the slab. You know, the classification came from the Stephen J. Snyder. Then it has been gone up to from 4 to Maffei classification, and it went to up to 10. So the if you want to understand, if you want to diagnose classically, stamp is a slab tear, it has to be done with the only with the MR arthrogram. Another part of the question was the Hagel lesion. It's a very good question because classically the Hagel lesion is the humeral avulsion of this front ligament. So also there can be the reverse one. So the Hagel lesion, suppose there is instability, the labrum has not been torn from the glenoid side, is the ligament has been torn from the humeral side. So once we go back, unless during the arthroscopy we examine it, then we can miss it. The problem is that clinically also you have to find that there is tenderness on the front of the of your humeral head. And once you see the MRI picture, as I have shown you during the discussion of the MRI, how the classic the Hagel will look. It is known as the inverted J sign. Also, you will be find in the axial cut also, you will be finding that the humeral ligament has been avulsed from the humeral side. So your clinical test, tenderness on the front of the humeral head, and also your MRI will tell you that this is the Hagel lesion.
Okay, does that answer
Yes,
your
I think
question, Rajan?
Yes, Rajan.
Sir, if there is a question regarding rotator cuff tear and adhesive capsulitis, so by age we can mostly we can differentiate that if it is younger age, then that will be rotator cuff tear, and if the older age, then will be adhesive capsulitis or frozen shoulder. If
No, it is not like that.
Unfortunately, adhesive capsulitis and rotator cuff tears both happen in the same age group, roughly the middle age and elderly. It's the instabilities which are in the younger age group. Okay.
Yes, sir. So basically, the frozen shoulder group or the rotator cuff group that falls mostly beyond 50s. So they fall in the same category group. Younger people, if it is coming as a frozen shoulder, always look for the medical issues first. Or they are, because of the trauma, they might be having some problem. But rule out the medical issues first, rule out the traumatic issues. Because they might be having some partial calf problem. Even in the young people, after some injury, there is some partial lesion of the calf. Calf problem in the young people, classic calf tear in the younger group less than 40 is a rarity.
Okay. So I think any more questions? Otherwise, we'll call it a day. Thank you very much, Dr. Samanto. Swarnendu, it's been great to have you here. And hopefully we'll have you here again soon. Okay, so thank you very much. And with that, I will call this meeting
Thank you,
to a
sir.
close.
Thank you, sir.
And look forward to
sir.
further
Namaskar.
interactions. Thank you.
Namaskar,
Bye.
sir.
Bye, Swarnendu.
Thank you very much.
Bye,
Thank you.
everybody.
Thank you.
you.
Thanks. Thank you, sir. Okay, sir. So thank you, sir. So today we are closing now.
Recording
Sir,
service. Even me are all
recording.